Thank you very much indeed. And colleagues, Minister Fian, all of those who are participating this afternoon, it's a great privilege to be here to present to you the Childhood Obesity Surveillance Initiative, Round 5, the results for 2018-19. And Dr. Lachlan, Mitchell and myself will go through these now on behalf of the National Nutrition Surveillance Centre. So as we see in the first slide here, the global prevalence of childhood obesity is a major challenge to us all. We have, of course, a problem with adult obesity as well, but childhood obesity is particularly important because of the fact that it tracks potentially over the life course. And as Sarah indicated earlier, it presents a very important challenge in terms of morbidity and mortality over that life course. We see here the world obesity data from the Federation in London in 2019. And you can see for the prevalence of overweight, including obesity for both girls and boys, ranging from less than 5% to 25% plus, that this poses a major challenge across the Americas, in Australia, in parts of the Middle East and Europe. And of course, there's also the ongoing issue in relation to undernutrition. And there are some particular areas in the African region that have been particularly recently affected. So this poses us a major challenge to be addressed. And if we move to the next slide, we have seen a number of very large-scale studies in recent years that have benefited from pooling data from studies over time. And these have allowed us to look at this over the last 35 years or so. And here you see this first one from the Global Burden of Disease Studies, which looked at the prevalence of overweight and obesity in children over a 33-year period, representing a very large database of over 1,700 studies in 188 countries. These data look at children from the ages of 2 to 19. And we use here in this particular study both self-reported and measured height and weight using the International Obesity Task Force cutoffs. So the first thing I think to note is looking between the developed and the developing countries for both girls and boys between 1980 and 2013. Rates were 16.2% in developed countries and half that in developing countries in 1980, and have now climbed in this analysis to 22.6% in girls and 13.4% in boys in the developing countries. And similar effects are seen in boys. This also shows us observed distinct geographical patterns, particularly high rates emerging in the Middle East and North Africa, in the Pacific Islands and in Caribbean nations, as we've seen in the earlier slide. If we move to the next slide. Here we have a data again from the very large scale global burden of disease studies. And these again have had the opportunity of pooling international data sets. Here again, 1,400 plus studies in 173 countries. These data look at children from the ages of 2 to 19 years, and again look at self-reported and measured height of weight with IOTF cutoffs. And we see here from 1980 right through to 2015 that this middle yellow line here of the global trends have been upwards, and also that the quintiles, according to the socio-demographic index of development, show very considerable variation. And these were narrower in the 80s and now show a broader range in 2015, but increasingly we're seeing that this is moving from the developed to the developing countries. A notable point is that the rate of increase in child obesity in that period had been greater than the rate of increase in adult obesity. And continuing to the next slide. The NCD risk study published in The Lancet was indeed the largest yet, and that was produced in 2017, and it looked at worldwide trends in body mass index, underweight, overweight, and obesity from 1975 to 2016. And this is an important study because it has incorporated a number of the Irish data sets that we've been collecting in this country, including the SLAN and some of the earlier COSI surveys. And again, it looked at trends of BMI by global region from 1975 to 2016 in 2,500 pool studies with 31.5 million children and adolescents from the ages of 5 to 19 included in that. This paper is worth looking at in detail because it looks across the globe at these trends. And it does show, which is interesting and important to what we look at later, that children and adolescent patterns have plateaued in many of the higher income countries, albeit at high levels, but are accelerating now in Asia, with trends no longer correlated with those of adults, which is important in thinking about the causal patterns. And we see here, for instance, where blue goes from underweight through green to healthy weight, through orange and for overweight and obesity, that these were and will continue to be appreciable trends, but in recent times have been plateauing. And that is a significant issue for further investigation. Moving on then to the COSI study, as Sarah said and Stephanie said in the introduction, Ireland was to the forefront in joining this consortium, which has been led from the European Office of the World Health Organization. And this childhood obesity surveillance initiative has been going from strength to strength since it was established. In round one here in the lighter color, Ireland was one of the early participants. And we see through rounds 2, 3, and 4 over the ensuing decade, more and more countries have been joining in this. So why is this important if we're focusing on a region as we are in Western Europe? It is very key that we would have standardized and systematic data so that we can compare within and between countries, and that these protocols are developed on that basis. So we have the basic examination data that is being collected through standardized protocols, and also additional survey information on the school environment and on the families that are participating in these studies. They afford us an opportunity to look in more depth at the variations within and between countries. And they also, provided countries can follow the stipulated requirements for the protocol. In our case, we have data for children exactly age 7 as part of the international part of the consortium. It is possible for countries to collect additional data as we have been doing here in Ireland. I stress these are for surveillance purpose. This is not a screening exercise, but it's also very important because the school is a key health promoting setting, and these data are collected in that environment. If we move to the next slide. In these rounds, we have been reporting at the level of the international data, but also the national data. A very large volume of peer-reviewed papers are now coming out, which are looking in more detail at what we can learn from this. But I'll highlight here the patterns of overweight and obesity from the round 4, 2015-17, to show you that we can compare data from girls and boys in the blue and girls in purple here, but also that it is quite variable in terms of this using a systematic protocol. And so it's an important key to understanding why these patterns vary in relation to socio-cultural and other influences, but also boy-girl patterns aren't always systematic. In some places, the rates are higher in boys and sometimes in girls, and vice versa. And this is an ongoing issue to understand. And if we move to the next one, where are we at the moment? Well, as of June this summer, what countries or entities have completed the COSI round 5 data collection? Here again, we see the map, and we know that 34 countries had completed the wave in 17-19 collections. This includes the large urban conurbations in Bremen in Germany and Moscow in Russia. And these countries have now collected the data, and we are in the course of cleaning those data, analyzing them. And today we will be giving you our round 5 COSI data. 6 countries, unfortunately, including the city of Ekaterinburg in Russia, were not able to complete data collection because of the COVID pandemic. And 4 countries will not be collecting data in this round, with 2 countries with no available data as of the summer. And of course, this is an important issue because the COVID-19 pandemic has posed a major question in and of itself as to what influences that might have long term on rates of overweight and obesity in the population for children and adolescents and across the life course. And more research will be certainly required. But for the purposes of our presentation today, our data were undertaken and collected in the autumn-winter of 18-19 before the onset of the pandemic. I'd now like to hand over to my colleague, Lachlan Mitchell, who will take you through, and we have the reports 1 published in 2008, 2 and 3 in 2012, round 4 in 2015, and Lachlan will talk you through the findings from round 5 from this point. Thank you.
Thank you, Cecily, and thank you, Sarah, for that introduction. I'd like to shift the scope of our focus onto now the present round of data collection for the Childhood Obesity Surveillance Initiative, starting briefly by giving a bit of a background on the methodology used in the present round. 185 schools were invited to participate in round 5 of COSI. These schools were selected based on their previous participation in round 1, which took place in 2008. These schools varied in size and location. We were able to distinguish between urban and rural schools. And schools classified as disadvantaged under the DESH classification system were also included. Based on the rigorous selection protocol used in round 1, this sample of schools was representative of all Irish schools. The primary objective of COSI was to assess the weight status of children in 1st, 2nd, 4th and 6th class. For this to take place, researchers went into schools and collected basic anthropometric assessments on children in these classes. In addition, the participating schools were asked to complete a school survey, which examined physical activity and nutrition and physical activity environments inside the schools. Families of participating 1st and 2nd class children were also invited to complete a family survey, which collected data looking at nutrition and physical activity outside of the school environment in the family setting. Considering the participation rates, as I said, 185 schools were invited to participate in round 5. Of these schools, 135 agreed to take part. This represented about just under 75% of the invited schools and is a similar participation rate to previous rounds of COSI. Included in those 135 schools were 21 DESH schools out of a possible 26 which were invited to take part. Overall, over 5,500 children were examined in COSI in round 5. This represents about 60% of all eligible children that were in invited schools. Participation rates were similar between boys and girls in round 5. However, there was a difference in participation rate between children attending disadvantaged schools and non-disadvantaged schools, with children attending the DESH schools participating at a rate of just over 45%, whereas the non-DESH schools were approaching 60%. Moving on to the results specifically, overall we found that approximately 1 in 5 children were classified as having overweight or obesity using the IOTF cutoffs. These rates tended to increase with increasing age. You can see the figure on the left there. You can see that in grades 4 and 6, the prevalence rates increased above 20%, whereas the lower grades, so 1st and 2nd class, the prevalence rates were below 20%. We also identified differences in prevalence rate between boys and girls. This was primarily driven by children in 1st and 2nd class. Again, looking at the columns on the left side of the figure, you can see that the prevalence rates in girls is up towards 20%, whereas in boys it's down below 15%. And this is driving that significant difference between boys and girls in overall prevalence. We found that also overall approximately 60% of children were classified as underweight. Primarily, most of these children were classified as category 1 underweight. Based on our assessment techniques, we were able to also compare the prevalence rates between schools classified as urban and classified as rural. We found that there was no significant difference in prevalence of overweight or obesity based on attending an urban or a rural school. And this followed the same trends identified in previous rounds of COSI. Similarly, we were able to distinguish between the disadvantaged and non-disadvantaged schools. One of the primary outcomes that we identified in round 5 was a significant difference in prevalence of children who have overweight or obesity based on attending a disadvantaged or a non-disadvantaged school. What's particularly important is that trend of an increased difference between the two categories with increasing age. Looking at the figure here on the slide, we can see that in grade 6 in particular, the disadvantaged schools, so children attending those DESH schools, the prevalence rates was approaching 40%, whereas the non-disadvantaged schools, prevalence rates was below 20%. So as I said, this is one of the primary outcomes to come from the round 5 data collection for COSI, and is certainly a trend that was identified previously, and it reflects worldwide trends based on socioeconomic disadvantage. If we start to examine the round 5 data in comparison to previous rounds of data collected here in Ireland in the Childhood Obesity Surveillance Initiative, we can see that the trend for a plateau in overweight and obesity prevalence, which was identified in round 4, appears to be continuing in the present round. The figure on the left there represents overweight and obesity prevalence in first-class children throughout rounds 1 through 5. And you can see there that there's a distinct levelling off of prevalence moving from round 3 through to rounds 4 and the present round 5 data. Likewise, the figure on the right, which presents prevalence data for children above first class from rounds 2 through to 5. Again, you can see that there is a distinct levelling off in prevalence when you look at those the bars on the right side of the figure, moving through rounds 3 through to round 5. The question to come from that would be, therefore, how does this data compare to worldwide trends? Well, there is some evidence to suggest that there is a plateau in obesity prevalence amongst children in developed countries, rather. A couple of examples here. The first figure on the left there comes from the Australian Institute of Health and Welfare. Their most recent data collection survey shows that there is what appears to be a trend in a plateau of prevalence amongst children. Likewise, evidence from the Health Survey for England between 1995 and 2018 suggests again that there is a plateau in prevalence in children in most recent years. As such, the evidence that we've identified here in round 5 of COSI, in that there being a trend in prevalence, appears to be reflecting worldwide prevalence rates amongst developed countries. Shifting the focus more towards the school survey now, which again, as a reminder, collected data regarding the nutrition and physical activity environments in schools. We can see that the school environment for nutrition, we identified several positive outcomes. Firstly, most schools are free from advertisement of energy-dense and nutrient-poor foods, and most schools include nutrition education in their curriculum. Furthermore, all schools are free from vending machines, which fits in with the school environment guidelines here in Ireland. 93% of schools are free from sugar-sweetened beverages, and 92% of schools are free from sweet or savoury snacks. And about a quarter of schools provide fresh fruit for their children on site. Looking also at the physical activity environment in schools, again, there were several positive outcomes to be identified. All schools have outdoor play areas available for children to access, and all schools include physical activity in their curriculum. The median physical activity duration is 60 minutes per week in schools. 3/4 of schools, in addition to having an outdoor play area, also had an indoor gym available for children. Other data to come out of the school survey regarding physical activity environments showed that more than 60% of schools organise sport or physical activities for children outside of school hours. Unfortunately, though, 2/3 of these schools reported that less than half of children actually attend these activities. Finally, we also asked schools to indicate perceived barriers to meeting physical activity recommendations in the school. 45% of schools indicated that facilities were a perceived barrier to meeting these recommendations. and 37% of schools perceived time to be a barrier to meeting these recommendations. So in conclusion, as I said, the prevalence of overweight, including obesity in Irish school children, appears to be stabilising in around that 1 in 5 children rate. There were differences apparent between boys and girls, and this was more so apparent in the younger years. Having said that though, the prevalence rates tended to increase with increasing age, and as Sarah and Cecily have both indicated, we know that childhood obesity does track into adulthood obesity, so it's of concern that as we move through the ages in primary school students, we see an increase in prevalence of overweight and obesity. Also of concern was the distinct difference in prevalence that was identified between disadvantaged and non-disadvantaged schools. Again, this difference was increasing with increasing age. Moving forward from here, it's essential that we can identify and respond to mechanisms responsible for these differences between boys and girls and the difficulties that socioeconomically disadvantaged individuals and families are facing. To finish off, I'd just like to formally acknowledge the assistance that we received from the Health Service Executive, the Department of Health, and the Department of Education and Skills in conducting this study. I would also like to thank the World Health Organization Regional Office for Europe. As Cecily has indicated, the Irish branch of the Childhood Obesity Surveillance Initiative is a part of the wider European Childhood Obesity Surveillance Initiative. Of course, I'd have to acknowledge the participation of schools, teachers, parents and children. Without them, we couldn't be conducting this kind of surveillance research. I'd also like to formally acknowledge the wider National Nutrition Surveillance Centre research team here at UCD, Dr. Sylvia Bell-Surratt, Dr. Miriam Heinen, Dr. Celine Murren, Isabel Stanley, Dr. John Megan, Tara Hegarty and Lara McCann. Thank you for your attention and I look forward to the panel Q&A later on.